strategy that's designed to understand the neurophysiological principles of the locomotor system. It's based on developmental kinesiology, postural ontogenesis, and the neurophysiological aspects of the maturing locomotor system. Keyword there is maturing. So what does this include? I've had a lot of students in the past that are like, all right, DNS is breathing. Well, that's maybe 1% of it, and this strategy provides a lot of intervention. You can assess patients through it, you can treat patients through it, you can develop exercise interventions, and it provides a greater understanding of the functional strategies of the human locomotor system. So here on the screen we have the basic principles in a specific order. Diaphragm function is the first thing that I'm really looking at in a patient, and a lot of people think about the diaphragm that it's just a respiratory muscle, which is very true. We take, I believe, correct me if I'm wrong, Sean, 20 to 23,000 breaths a day. So that's a lot of breaths, and if that is altered, that's a lot of dysfunction throughout 24 hours. So that's the first thing that we're looking at. Number two, we're looking at the integrated spinal stabilizing system, and we're going to go into that and the specific muscles that are involved in that. Sagittal plane stabilization, which is the first type of stabilization that we achieve as humans, and this is going to usually be achieved between the 3 and 4.5 month mark of our life. Moving on, functional joint centration, and essentially what that is putting the joint in the greatest optimal position for biomechanical loading, which is going to increase our force production and our performance. Differentiation of muscle pulls, both in the closed kinetic chain and open kinetic chain. Moving into isolated motion, constituting to a global function. And lastly, we have different movement patterns, undifferentiated with a squat or bear positioning, and a differentiated pattern, which we'll go into much later, with ipsilateral and contralateral patterns, which are two patterns that our body simultaneously transitions in between. So, developmental kinesiology, why is this important? Well, it emphasizes the existence of the CNS locomotor control, and essentially all of this, the way that our CNS matures, it happens automatically. Okay, nobody needs to teach us how to grasp a toy. Nobody needs to teach us how to roll over. So this is all ingrained in our central nervous system. And if somebody is developing, ideally, there are different patterns and positions that the body is going to be in over time. And essentially, as a clinician, we could define the developmental age by assessing the achieved quality and stage of these motor patterns. Okay, so if you have somebody that is, for example, 7 months old, and they're really not able to go from supine to a prone position, and they're really getting stuck and aren't able to achieve that rolling over from supine to prone, the 7-month mark, we're, for example, now we're thinking about, all right, something may be going on. There's some type of delay. So essentially, this is the importance of developmental kinesiology with this approach. Postural ontogenesis, one of my favorite words. So, human locomotion, unlike many other living things on this planet, is immature at birth. Bambi comes out of the mother and is able to run. A lot of species out there, actually, their mothers disown them right after birth. Imagine if that happened to us. We would not be able to function. And
I think it's insane when you see an animal get born and they can walk immediately.
Yeah.
When you watch the Discovery Channel or something, and they're just jog out of there. What?
I'm ready to go.
Bambi did struggle on ice, though. Wasn't stable enough.
Yeah. So it's quite interesting, and if anybody has any comments about this, if you have a baby that is neglected throughout their development, perhaps there's no emotional support, perhaps there's no tactile and afferent feedback to this baby's central nervous system, they are going to develop differently. So it's very important in regards to development of the maturation of the CNS, but also structure and function of muscles and bones. Postpartum CNS requires maturation, and moving forward, this will cause anatomical maturation of our system. Once again, like developmental kinesiology, this is genetically determined and automatically dependent on CNS control and afferent stimuli, which is what I just basically touched upon briefly. Postural ontogenesis ensures active posture, and all the positions in the joints of our body are determined by the anatomical shapes. Our muscle function are encoded within our CNS, and basically these motor programs and motor functions become higher level as our CNS matures. So this is a nice representation, postural ontogenesis 101. So our CNS is programming, which drives muscle function, which also drives the anatomical shape of the joints. Okay, so for example, if we have some type of CNS lesion, that is going to change the way that our muscles are going to be activated. It's going to change the ability for us to move. And at a young age in regards to development, that is going to change the way that our joints are going to be positioned and develop.
When you say lesion?
For example, I'm going to go into that, but for example, let's say cerebral palsy, for an extreme case, that's an extreme disturbance, of the central nervous system.
What would be a simple lesion? Okay,
let's say somebody that has, let's say take a very Pes Planus Foot, very flat foot, for example. Okay. Is there some genetic component? Absolutely, everything has some type of genetic component. But we know that we could also change the function of that foot. So basically, if you look at people, like my family, everybody's left foot is flat. So essentially from my parents, the genetics, and also perhaps how I was developed, I've acquired this, flat foot. And then moving forward, I have a very bad right hip. I have leg calf perthes in my right hip. So that also could be acquiring my left foot. So basically something like that. Leg calf perthes, I've competed at a high level, but if you look at my x-rays of my right hip, at age 5, it was collapsed. I lost blood flow to that joint and completely collapsed. So that would be still a serious condition, not as serious as cerebral palsy or some other things like that. But my CNS, the muscles within my hip is completely different than yours, and my joint looks completely different than yours as well. Like if we just took a picture of your hips at 5 and my hips at age 5, totally different.
And you're saying because of the flat foot? Or you think there was something in the right hip also? Or do you think they're related?
I think there was something in my brain.
Okay.
Yes, in the brain. So, the hip on the left, that's somebody who has cerebral palsy. Okay, look at the orientation of the femoral neck in the acetabulum. Look how the greater trochanter. It's just almost vertical. That's probably like 150 to 160 degrees. The picture in the middle is somebody that has leg calf perthes disease, and you can see the orientation of the greater trochanter.
Which disease you said?
Leg calf perthes disease, which is a vascular necrosis, which is of the femoral head. So essentially, the person in the middle lost blood flow to the hip joint. Okay, they lost blood supply to the bone was inhibited, and therefore, the nutrients that are supplied within our bloodstream, it's not healthy. Okay, so the development is going to change, and this is usually diagnosed between ages 5 and 8 years old, most predominantly in males, but you do have it in females, usually unilaterally, but you do see it bilaterally sometimes. Okay, and then also the picture on the right, that is a healthy hip bilaterally, and let's just look at all those 3 pictures and see how that all those 3 shapes right there, that was determined between ages 3 months and 6 months based on development. Okay, obviously the patient on the left was not able to upright themselves, or in the 3-month position, which we'll get into. I guarantee you they were not able to get into a 90-90 supine position at 3 months old. Guarantee you, because if they were, that hip would not look that way. Same thing with the one in the middle, and the one on the right, for example, let's just say that that was ideal development. Okay. Some extra neuro talk for us. We have 3 levels of postnatal CNS maturation. The neonatus, the first year of life, and 2 years and greater. So when we're a neonatus, we're working on the spinal and brainstem level. Okay, we have functional immaturity, structural immaturity, no balance, no postural function, and our primitive reflexes are positive. Within the first year of life, which is subcortical integration, we have these maturation of postural locomotive patterns, muscle coactivation. We develop the stepping forward and support function. And over time, our primitive reflexes will start to delay and most likely diminish, and you really won't be able to provoke a primitive response. 2 year.
Is that like when you touch like when it moves?
Let's say
as a baby.
Yeah. Yeah. So let's say, for example, there's a reflex within the hand.
Yeah.
If you're over here and I'm 3 months old, it's gonna go like this. Okay. Or oral facial reflex, I believe it starts to diminish after 3 months. If you took the hand, it's gonna go like this. You know, if I do this, you have the ability to like not have that
okay.
reflex. Does that make sense?
Mm-hmm.
So, moving forward, after our second year of life, this is where we start to have motor learning. We have selected movement. You know, ask somebody, when did they start playing the sport? Oh, I started when I was 2 or 3. Okay, so this occurs at a very young age. We have motor dexterity, agility, and sports performance. Similarly to the last slide, in the subcortical level, from 6 weeks to 1 year old, we start that basic sagittal plane stabilization. We have basics of support, we have basic functions, and functional joint centration through development. And in the column to the right, we were talking about the cortical level, which is greater than 2 years. We have practical and agnostic functions, selective movements that we desire, motor learning, and the ability to have conscious relaxation. So all in all, abnormal development in the brain causes abnormal posture, which will cause abnormal geometric anatomical maturation, which will cause abnormal locomotion. If we have ideal brain development, we're going to have ideal anatomical maturation, which is going to cause optimal biomechanical loading and muscle pull, which will cause ideal skeletal maturation, which will thus then result in ideal locomotor function. The brain. Yes.
How deep into ideal development do they go? And when when do you intervene? Do they talk about when?
Great question.
Like I read a book about vision, and they talk about, I don't know what the exact number was, but around 7, everybody should be in. And I'm not
7
saying
weeks?
this is the thing. No. So this particular book said that around 7 years old, everybody should have some level of lenses. You know, whether that's true or not, I don't know. But that's what they're saying. So is there a point where they say, you know, at this age, we need to start looking at, because this is where things can get funky.
Yes, absolutely. Great question. And I'm glad you brought that up, because I did not put it in the PowerPoint because it's quite extensive. But essentially, I had the opportunity to observe pelvic collage, evaluate many babies, okay? And for example, with somebody that has some type of central nervous system disturbance, let's say, for example, cerebral palsy, he says we must diagnose this within 6 weeks, okay? And he actually scans almost every single baby that is born in prop. And how does he?
Really?
Yes. And how does he do this? And how can you diagnose such a disturbance, you know, at 6 weeks old? Well, this all goes down to how our brain is wired. You know, he would take a baby, we have postural reactions. Okay, you know how everybody's like, all right, you have to caress the baby and stuff like that, make sure the head is like, you know, not sagging like this. Well, he will take the baby and lift it up from the arm and the leg and see how the body reacts, okay? And essentially, if I showed you pictures of how through their postural reactions and changes of body positioning, it will directly correlate to the developmental positions that I'm going to show you later. So if he lived, for example, if there was a baby that was laying right here, okay, and I grasped the arms and lifted up the baby.
This would be the weirdest seminar ever.
No, it was wild. It was wild.
Just bringing babies in, like
Yeah.
on
Let's
tables.
just sit right here.
When you're establishing norms in the sense of how a child is handled in Western culture rather than other cultures, and I believe there might be a difference in how they actually literally handle babies at a very young age. So is there a comparison? How are you trying to establish the proper way of a baby reacting to a particular hold? Maybe cradling baby is not the best thing in the world, and maybe we have it backwards. I don't know. But obviously other cultures treat things differently. It's not necessarily wrong, so we may think it looks odd and harmful, but maybe it's not. I don't know. But it's just I was just thinking like how's he measuring, or maybe you're not measuring. I don't know. But how are you getting your norms basically?
Beautiful. All right, great question. So going back to what I was going to demonstrate here, and please anyone who has any type of knowledge in this, please intervene and let's have a great discussion. But if I take a baby and I lift up the hands, okay, you should see the baby be able to activate the deep cervical neck flexors at a particular point of development. Okay, so if I'm lifted up, I'm a baby, right? So if I'm lifted up, and I'm like this, I have no deep cervical neck flexor activation. We should have that at 3 months old. Okay, and essentially, this is going to correlate. So if I'm laying in the supine position 90-90, right? Okay, I need deep cervical neck flexor activation and to be part of the integrated spinal stabilizing system. If that is inhibited, I'm not going to be able to get my legs up. Okay, so it's similar to the postural reaction, and it's a quick test. You're looking at it's very specific. You have to know exactly what you're looking for. But he would lift the baby up. You'll see that go. Okay, boom. We know something. There's a lack of some type of development.
Because I can't remember what it was that I was reading. It might have been a newspaper article or a video of something what we would call primitive tribe, or how they were handling the baby, which was completely normal to them, but to like Western,
Yes.
it was like, oh my God, that's like abuse.
Yes. Yeah.
If on the other hand, if they're completely functional as an adult, however, they're measuring functionality in their society.
Yeah.
Is it wrong? I don't know.
Yeah,
So
absolutely.
it's just interesting. We always have our ways of doing it, but other cultures may have other ways of doing it.
Yeah.
Which one's really
Who's
right?
right? Yeah, exactly. And then what the parents use with the baby's in front of them, right, and the legs are like this around the mother, okay, and let's say the mother's walking around in the mall with their child for 2 hours. You just put this baby in a position like this, okay. When our structure, our CNS is maturing, it's at its most vulnerable position, and now we're putting them in these volatile positions that can change the structure of the anatomical hip joint. So it's there are baby handling courses,
I was literally just going to ask that.
There are baby
like DNS
baby handling courses.
Wow.
Absolutely. So it's quite interesting. I have not studied that course in particular, but I will get there. And it's interesting, you see parents are so eager to get their baby to walk. Let them verticalize by themselves. They have to be able. It's okay for the baby to struggle. Oh, I don't want him to struggle. He needs to struggle in order to develop him or herself. That CNS has to figure it out. So if you verticalize a baby too soon, you will have changes. Hopefully not, but volume and frequency and all of that duration, that's where we get into trouble.
So I have something that's kind of weird, but it always stuck with me. My chemistry teacher in college said that, so I don't know how correct this is, but he said that if babies go from like sitting to standing too quickly without crawling for the necessary time, that like they won't develop proper like upper body musculature and like have breathing problems. And he said that like his baby did that, and he just karate chopped his knees when he started standing. So then he like kept crawling for like 6 more weeks. Something like that.
Not today.
That's a good father, no?
I think that's
Yeah.
lesson 1 in the baby handling.
Yeah, so it's interesting. All of us in this room went through the same development, and nobody taught us. Okay, so our CNS has to figure it out. Any questions?
just to reinforce that's what like our neuro professor Casey and I was talking about when talking about pediatrics, where in terms of walking and ambulation, if the kid is walking at 12 months versus 15, that's okay. There's normal variation, and you just have to let the central nervous system kind of do its thing, and some people may be faster than others, so I guess there is like a variation in what normal is, and that's what I guess can be tricky. Like we always think, oh, what's ideal, but there might be like some wiggle room in terms of what ideal is and what normal development is.
Yeah.
It's amazing. Parenting these days, not that I'm a parent, but I just, I'm going to freak out over the possibility that your baby's a little bit delayed. Now they're going to fall behind in their studies, and they're not going to get into the right preschool, they're not going to get into college. It's freaking.
Yeah.
I heard that one of the worst things you could do is put them in that little thing where it's like supports them for standing, and then they walk,
and then
they
Oh,
can like
really?
jump a
Or
little
the
bit,
jumper, yeah.
and like they're like held up in like a diaper type situation, and they can walk way earlier, and now the parents can be like, my kid is killing.
Yeah, yeah. You just verticalize them before
You
that.
literally,
Yeah.
Wait, so I have a question, because I remember I sent you the video of my nephew.
Yeah,
He was
yeah.
3 months old and he started standing, and you were like, well, like, you can't push it too much, blah, blah,
Yeah,
blah.
yeah.
Well, he loved the thing that he would stand in and like play with or whatever, and he would like bounce off the floor. And now that he started walking and he's in shoes, like his leg, he's like bow-legged. And his one foot kind of turns in, and my sister's like freaking out. But I told her, I was like, well, don't like hold him up as he's 3 months old, because you told me that.
Yeah, yeah.
And now like he's kind of like walking funky.
Yeah, no, it's of course it's exciting to get a baby to be
Right.
vertical, but you know we have to let them figure it out.
So is that something that will stay, like his position of his lower
You know,
limbs?
You know, with proper intervention and stuff like so look, for example, you know, his muscle pulls maybe are different because his structure is so okay. Ready? We verticalize the baby sooner than we should. The brain is going to recognize that, right? And then muscle function is going to adapt to that. And that what do muscles pull on it? They pull on the bone. So if I have this pulley system that's pulling, I'm going to have change.
Is there any predictable things that you see like, oh, here's another one of these, that results from being upright too early? Is there anything that you see just like it's seen quite often?
I just see parents wanting to just verticalize very soon. They want to walk with their kid. You know, it's an exciting thing. And then I just look at the position, all the different type of ways to carry the baby. You know, having the legs completely spread apart. It's just like it may be more comfortable for the parent, that's very important as well. You know, but those are the two things that I usually see.
Was there any predictable outcome in teenage years or adult years that you're like, this person's going to have problems with this at 20 years of age? Or it's just very individualized?
It's very individualized. You know, I've only been studying this for 4 years, so in a couple more years, hopefully I can answer that question a little bit better. But definitely, based on their motor behavior patterns and the age and sequence, the age in which they're doing some type of position, the quality in which that they're carrying that out, and the efficiency, you can predict that okay, this person might have a poor anatomical hip. You know, and in regards to my knowledge, that's what I would be able to say in regards to complete precise, like their you know, IP of the second digit, you know, is going to be messed up. No, I can't do that. I can't do that yet.
Yeah. You know, a lot of the concepts that you're talking about is very much developmental in nature. There's also this concept called the critical period. That critical period is when your CNS is maturing at a certain level, and then you have to have the right exposure to the right environment in order for all of the pieces to come together. You know, the example that you gave about the bowing of the leg, you know, for example, yes, you have all these muscles working, trying to adapt to the conditions that you put the child in, but there's also other structural issues, like for example, the density of your bones not well formed, right? And so thus, you're going to be structurally deficient in that sense. Same thing goes with, you know, a lot of the kids who may skip from, say, sitting upright to walking without having to crawl. You know, you'll see a lot of literature coming back about the use of so-called tummy time, because because that's how the concept that you talk about, the sagittal orientation, it's so important. I mean, the being on prone and then working on all of the different kinds of, your deep intrinsic muscles of your head, of your back, as well as your longitudinal extensors, are working together to make those little refinements in your body, so that when you start sitting upright, you can actually turn your body all over the place, versus, you have this kid, you wanted to get them upright, and then they're gonna be so clumsy as shit, when you're walking, and then you also have all these types of sensory issues, because your vestibular system also has to develop, not just kind of like linear vertical. It has to happen where there's some rotational components to it, going from prone to supine to prone, so supine to prone and whatnot.
Thank you, Sal. Appreciate it. So, moving forward, this is the integrated spinal stabilizing system of the spine that I was discussing. And essentially, this is a perfect segue to what Sal was just speaking about. What he said is everything is working synchronously, in synchronization. It's a global function. No muscle works in isolation. Our body is made of slings, okay, and they work in unison. Take the force production of a 6-month baby's bicep. It's going to be much different. Or let's take a baby in the 3-month position, supine 90-90 position. 90 degrees of flexion at the hips, 90 degrees of flexion at the knees, and 90 degrees of dorsiflexion. Oh well, we'll say neutral dorsiflexion. Well, a baby could play there all day. If I try and sit in lay supine in that 90-90 position, I'm going to go a couple minutes, but I'm not going to go hours, so it just shows, I could bench press more than a 3-month baby. I pride myself on that, I could squat more than that 3-month.
You'll be humbled enough.
Yeah, exactly, but it's amazing. Like I talked to some of my students, and I'm like, well, have you ever thought of that? The baby is functionally working in this position for hours, and here we are, we have some Division I athletes, and even pro athletes that may not be able to sustain that position for more than 2 minutes without some type of compromise. So here we go. When I'm looking at the spine or posture, I'm thinking about the deep cervical neck flexors. I'm thinking of the diaphragm, the abdominal wall, the pelvic floor, and the spinal multifidi. So essentially, we have deep cervical neck flexors are obviously in our cervical region. The diaphragm is in our mid-thoracic, and then the pelvic floor is obviously in the lower section of our abdominal cavity. And these should be aligned. I'm going to go into further different types of postures, and you're going to see how the orientation of these structures is compromised, and therefore their function will be compromised. You have an inspiratory position of the rib cage. We're going to have some issues. If we're completely extended like this, the diaphragm is not going to descend like a pistoning function. So it could, that's the way it works with the pelvic floor. We're not going to be able to have that. We're going to have the thoracolumbar extension, and so on and so forth. We're going to have further further muscular compromise and compensation. So the beloved diaphragm and pelvic floor, we could talk about this for probably 6 hours, especially with all of these great minds in the room. The pelvic floor and the diaphragm act as a piston mechanism. It's one functional unit. Okay, so I'm going to stand up for this one. So as we're breathing, okay, our diaphragm should descend downwards. Okay, if I'm in an inspiratory position through compensation over time, perhaps I'd text a lot like this, I don't know what I would be doing. But essentially, this diaphragm has to descend, okay? Well, we need another part of that function, that piston mechanism. This pelvic floor has to ascend, okay? And this is how we're going to go into it, but this is how we develop our intra-abdominal pressure, okay, within the abdominal cavity. So, this diaphragm must contract concentrically, the contours flattens and descends, the pelvic floor comes up, creating this piston mechanism. And now you could imagine if there's a balloon right here, okay, and I squeeze this balloon okay, where is that all that pressure going to go? Outwards, right? So that's where I need the eccentric activation of the abdominal wall to distribute the air pressure within the abdominal cavity. And what's interesting enough, the diaphragm and the pelvic floor have similar functions in regards to sphincter function. So even though that these muscles are located at two completely different parts of the body, their anatomy is quite similar. And both have respiratory and postural function. The respiratory part, all of us are pretty good. Well, we're okay at it. You know, are we ideal at it? No. But where a lot of us have a hard time is in regards to the postural function of both of these muscles. Look how all of us are sitting right now. Forward-headed posture, rounded shoulders, anterior pelvic tilt of the hip. We're not allowing this piston mechanism to be in an optimal position. Okay, this is one of my favorite representations. So what I was just trying to portray with myself is the picture on the right. Okay, so we're going to have the arrows of the diaphragm descending downwards. We're going to have the pelvic floor come upwards, and the arrows outwards towards the abdominal wall. That's where the air is going to go. Okay, I need to have that eccentric abdominal activation in order to maintain that pressure. If I have concentric activation of the abdominal wall, where is that air going to go?
Against the diaphragm and pelvic floor.
There we go. So this is how we maintain the equal intra-abdominal pressure regulation. So from knowing what we just discussed, the picture on the left and the picture in the middle, which is pathological, which is a pathological breathing stereotype and which is more of a physiological breathing stereotype. So the one on the left, that's going to be the pathological one. So we're going
for just as a crossover. I know a couple people studied PRI here. It's exactly when he says, you said left is the patho one, right?
Correct.
So in that the dome is the diaphragm there, and PRI we always talk about how it flattens out, and it's not like descending properly in the zone of apposition of PRI. So I find it very interesting as I go through this, and Neil, I'm sure you're seeing a lot of the similarities between the crossovers between this and PRI, and that's just a really obvious one right there.
Yeah, thank you. And you know, that's what I loved what Sean just said, is that there's a lot of carryover between PRI and DNS, and that approach. In my experience, and this is unfortunate, and this is one of the main reasons why I'm now teaming up with Sean and with our mission, is that why are we picking and choosing one side? You know, have as many tools in your toolbox as possible. Take a tool from neurology, take a tool from developmental kinesiology, take a tool from engineering. You know, that's what Stuart McGill does. You know, we must have a lot of tools in our toolbox so we can have variability.
So the white line is optimal position, and the greenish bluish line is the dysfunctional?
So
I think that's on inhalation, right?
That's,
Yeah.
yes,
So-
Is that
yes.
where you're showing inhalation?
Yeah.
Correct.
Oh, okay.
Correct. So the white diaphragm dome is just like at the resting position,
Okay.
the pre-position.
Yeah.
The one on the left, and I'm just going to stand up so this would be easier. So,
It's not descending.
yes,
Yeah.
so this is just the pre, the snapshot before I descend, and I have my inhale. Okay, so if I have a pathological breathing pattern, very accessory muscle dominance, I'm going to be, okay, so if we can see the axis of rotations, okay, we're going to be like this. We don't have this piston function, okay, I'm going to have the thoracolumbar extension, my deep cervical neck flexors, my diaphragm, and my pelvic floor are not going to be aligned. We're looking at the, and also look at, so we have the colorful contour here. See how this descends in this fashion, and this is almost linear and could be vertical.
So that's the inhalation.
Correct.
phase. Okay, that's-
Exactly.
okay, that's what I see.
Beautiful. And then also here, this would be representing the pelvic floor.
Okay.
Okay, this is coming up. We want this descend. Descend, descend. Descend, descend. And then eccentric activation. All right, so the breathing stereotype continued. We covered a lot of this, but essentially it's the relationship. We have to look at the relationship between the chest, spine, and pelvis. The upper ribs, if they are going to move, it's going to be more in the frontal plane. We don't want that sagittal verticalization of the upper thoracic cavity, because that means we're using a lot of our accessory muscles in order to breathe instead of our respiratory and postural muscles in order to breathe. The vertebral costal joints should be free rotation should be necessary. The lower ribs should widen, move laterally, and even with some pretty optimal breathers, they will descend in that function. The sternum should be stable. We should not see any movement there. And movement should occur at the sternoclavicular joint and not the acromioclavicular joint. So there's 3 degrees of rotation at the sternoclavicular joint, so very, very minimal. But if we have any accessory breathing patterns, it's going to be this. You're going to see that. Okay, a lot,
That's AC joint?
Yes, yes. Where I would like, see the difference? I'm going to exaggerate, but versus totally different.
So you said, I don't know what you said, lower ribs widen and move laterally, and you said in optimal breathers they also descend.
It could descend slightly.
Which is, yeah, that's only the second time I've heard. The first time I heard that, I was like, it's not, it sounded odd to me, but it's just that they're expanding and kind of,
Yeah.
it's just, I don't know if that's talked about quite
Yeah.
often.
Not
Because when I heard it for the first time, I was like, really?
Yeah.
And then it makes sense, but it's hard to picture how
Yeah.
it actually, when you get expansion, you think things are, because the ribs are actually rotating, but they externally rotate and then also descend. It's kind of hard to picture that.
Yeah.
They descend on inhalation or exhalation?
Inhalation.
That's the weird thing, when
Yes.
your ribs are actually rotating, but they're also
Yeah.
slightly descending. It's still hard. I still can't picture it,
Yeah.
even though I know theoretically it's correct. I just can't.
Yeah.
I'm
You
still
know,
having a
I'll
hard
try
time
and have a
picturing
demonstration.
it.
I'll try and demonstrate it. But you know what also blows my mind is when people say that the ribs are fixed and they don't move.
Who would say that?
That blows my mind.
Huh.
So is like the descent of the lower ribs like due to like the abdominal eccentric activation? If that's ideal?
Yes. The same mechanism that we just discussed in regards to the piston mechanism and abdominal wall function, we're going to see that. So if you think about it, we have the lower ribs. Okay. Let's say they're squished, right? We don't have any widening. Okay, down here. So if I have widening, look at my bottom 2 fingers. Automatically, if I just split them apart, we have some inferior movement.
That's all I need to say.
There we go.
Even if they rotate up, they can still.
Wait, can you say that?
So the thing can still rotate up and go down.
So these are my bottom ribs, right? Let's say I'm a very accessory breather. I'm all upper chest. Here, these are going to constrict. Okay.
When you inhale.
Yes. Oh well, yes. It's going to just constrict. You know, do you eat ribs? The intercostal muscles that we eat are the intercostal muscles that we
Oh,
have
that's
here.
what we're eating? The
Yes.
intercostal? Okay.
Yes, that's what we're eating. So
It's not the actual bone?
no.
Can you demonstrate that?
Yeah. So
Video.
essentially, we have
This
the.
will be on social media.
That's fine. So essentially, these are the lower ribs, okay? If I'm an accessory breather, I'm up here. We're going to have consistent shortening of those intercostal muscles, okay? I need to open these up. I could do it through some manual therapy, instrument-assisted soft tissue mobilization to help relaxate those muscles, relaxate the nervous system, so then we could then work on the breathing stereotype. So now we can have some expansion, and look at the lower 2 fingers. If we expand, automatically we're going to have some descent. All right, here's another beautiful representation. So, perfect segue. So look at the arrows on the right, look at the arrows on the left. Pathologic is on the left, physiologic is on the right. And actually, I wasn't even looking at this when I was constructing this presentation. Look at the abdominal, the contours of the actual abdominis. It's different. We see that little hourglass syndrome on the left. We don't see that on the right. Okay? If you take an MMA fighter, you are not going to see that hourglass syndrome, or else when they get punched, they're going to have bruising of their organs. They need to have that eccentric activation. Imagine if you had no eccentric activation of the abdominal wall and Floyd Mayweather punched you. No thanks. Also, another thing that we have to look at are the arrows of the lower ribs, which we just discussed with Neil. But then lastly, look at the orientation of the navel, the belly button. If we have pathological breathing, that is most likely going to ascend. We need either A, a descent of the navel with proper physiological breathing. It needs to descend, and or it's going to move like this. I don't want any superior motion of that navel. Okay? And also, the navel is very important. You know, if you look at swimmers that are trained well in practice, the coaches will say, breathe to your left and breathe to your right. The poor coaches are going to say, breathe to one side. And if you look at the tone of these athletes that aren't trained well, they're gonna okay, let's say I'm a right-sided breather. Okay, we're gonna have this, and guess what? This navel is gonna go to the right. So if I'm doing a postural examination on somebody, their body tone is telling me a story. I don't have to ask you anything yet. Your body I'm reading it like a book. And then whatever your history is and whatever you want to basically tell me is going to confirm. But essentially, hopefully I already knew that through my postural evaluation and the evaluation of your tone. Yes.
What do you think about umbilical hernia?
I would have to look into that more to discuss what I think about it. But I'll get back to you now.
I have a question.
Yes.
I don't know if this is like relevant because I have a PRI background, but like also with RPR, they always talk about the space you have between your ribs and your pelvis. And a lot of people that are heavy compensators have no space. They say you generally want like 3 fingers in between the top of your pelvis and the bottom of your rib cage.
Mm-hmm.
But if you're breathing properly and using the piston mechanism, that your ribs will open up and descend. Like how do you go from being compensating to having no space between your rib cage and your pelvis to then when they open up, like are they opening up forward? And if you're compensating, are they locked down?
I would say we would have to think about the adaptive shortening of the muscles. Okay, if we have pathologic breathing stereotype, 23,000 breaths a day, my quadratus lumborum is not going to be happy.
Yeah.
You know, there are going to be certain muscles that are not going to be happy, so we could have that adaptive shortening. You know, so perhaps that's what maybe the 2 fingers and it's not 3, because maybe that we had some adaptation. Okay, and also think about, this is perfect, thanks for asking that question, because we have a postural function of these muscles that we've been talking about. We're good at the respiratory function, we need the posture. If that postural mechanism is compromised, we have to get stability from elsewhere. Okay, so perhaps that's what the lack of space is. Of course, all of us are different in our maturation and our skeletal maturation. So of course we're going to have some differences, especially between males and females. You know, so there are case by case, but that would be my best answer in regards to adaptive shortening of muscles through compensatory patterns through 23,000 breaths a day. All right, so we look at all the different postures on the screen. Okay, similar to what Sean and Neil were showing us in their PRI seminars the last couple of weeks. So the one all the way on the left shows well centration of the cervical spine over the thoracic spine over the lumbar spine. Look at the dome of the diaphragm, look at the dome of the pelvic floor. Pretty in unison. Okay, that's going to descend, pelvic floor is going to ascend, and with that eccentric activation of the abdominal wall, those arrows from the abdominis is going towards the spine. Guess what? That's stability through air pressure distribution. Okay? So just by our breath alone, we could stabilize the lumbar spine better than if we had some type of compromise. So, you know, people like, oh, you have to do a lot of core, you have to do a lot of core, you got to do a lot of core. Well, first you have to learn how to breathe, use the postural and respiratory function of these muscles, and voila, you don't have to do 1,000 crunches a day. All right. Looking at the second picture, that's the open scissor mechanism, which we were talking about before. orientation of the pelvic floor and the diaphragm changes. You have the inspiratory position of the rib cage. And look what automatically that does to the lumbar spine, the thoracolumbar junction. It's going to go into extension. So if I see somebody with, a pretty prominent rib flare, okay, or inspiratory position of that abdominal wall, I know automatically, I don't have to look at their back, I know we're going to have thoracolumbar extension, okay, and we're going to have anterior pelvic tilt. So looking at the third picture, this is obviously a different postural pattern, but we see the rib cage is slightly more anterior than the pelvic floor. And in the picture on the right, we have a little bit the opposite. The pelvic floor and the pelvis is slightly more anterior than the diaphragm. Okay, and obviously look at the arrows, and that's going to cause, those arrows are going to be where a lot of our stress is going to come from. So obviously if you're the person on the right, fixing this orientation, or if you're this person, fixing this orientation, you'll hopefully, I want to achieve this. Intra-abdominal pressure. So we need the contraction of the diaphragm against the eccentric contraction of the abdominal walls, the paraspinals, the quadratus lumborum, serratus posterior, inferior, and the pelvic floor muscles. The correct IAP distribution is a feed-forward mechanism of the diaphragm. Before any type of movement, I should have this feed-forward mechanism. If I don't, well, we're going to have some compromise. The central tendon, created by the abdominals on the ribs, causes a puntum fixum, or a fixed point for our body. The lower ribs spread apart, widening the intercostal spaces, and intra-abdominal pressure increases in all directions.
I'm sorry, the serratus posterior inferior, where is that?
It's
Precisely.
down here.
That muscle is never discussed.
Never discussed.
I wonder, is it just one of those muscles that goes along for the ride?
Yeah, there's a good chance we're gonna get a fire alarm test, so. Stay poised.
I'm sorry, what were you saying?
So I've always looked at that muscle, and it's just no one ever talks about it. So I just always wonder if it's just a muscle that just goes along with, or if anyone ever has dysfunction in that muscle.
Yeah.
But no one ever talks about it.
Yeah.
I've always seen it, because I always look at my complete anatomy
Mm-hmm.
program. Like, why is that thing there? I know it's probably respiration.
Mhm.
I know it's a respiration
Yeah.
muscle, but no one ever, it's just never discussed.
Yeah.
I always wonder, does anyone have any dysfunction with that one? Because
Yeah.
no one ever talks about it.
Yeah.
We'll find it.
Yeah. All right, let's go find it.
It's there, it's just no one ever talks about it.
I just disarticulated my tongue.
Did you?
So we've been speaking about this for the last hour, and at 3 months to 4.5 months, we achieve the sagittal plane stabilization. This is, as Sal was mentioning before, we need this, okay? In our development, we need sagittal plane stabilization, then frontal plane, and then transverse. And this goes into regards to strength and conditioning of athletes, rehabilitation from the athletic training, chiropractic world, or the physical therapy world. We need to achieve sagittal plane stabilization before I go into frontal plane movements, before I go into transverse movements. If I have compromise at the sagittal level, I'm going to be falling into the frontal plane, okay? If I'm a golfer, okay, I'm going to say, that my sagittal plane stabilization is quite good, but not optimal, right? So essentially, it's a transverse sport. I'm moving in the transverse plane. Well, if my sagittal plane stabilization is not good, okay? If my intra-abdominal pressure distribution is not good, okay? If I lifted up my shirt, you're going to see an indentation on the left side, okay? It's hard to get air in there, and then that's what also we were discussing with PRI, right? Well, guess what? If I'm carrying out this transverse movement, 14th, 15th, 16th, 18th hole, I'm getting tired, so I'm going to be here, I'm going to come here. For example, I'm not going to get my weight to my right side. Also, when I come into the backswing here, look, I'm going to do this. I need to be here. Also, think about the cervical spine, the deep cervical neck flexors, the diaphragm, and the pelvic floor. The moment I do this, we just decentrated everything. So I'm not going to be.
With that being said, how far off do you find strength and conditioning, like classic strength and conditioning? What we see in like any weight room we go into?
Strength and conditioning in the weight room, the rehab room and PT places, and the rehab rooms in the AT departments. I think we can do much better job with our sequencing.
Right.
If you can't answer why is your A2 exercise in A2 and it's not A3, or why is it in your B section, it's not in your C
That's
section.
for sure.
If you can't answer that, that's a problem.
So like my thought is that everywhere I look, and anytime I've seen anybody get like a real performance change, like dramatic, it's just by changing position. I've been lifting for however since a little bit before high school, and I jump marginally higher. But when I change my position, I jump significantly higher, and it's just a little something, just a little change there.
Yeah.
So my thought is like, I mean, obviously this is like a worldwide
Dilemma.
issue at hand here, but like in my head, I'm much more gravitating towards the idea of, okay, well, let's just train a position, get into it, train strength there, and train aerobic endurance to maintain it throughout the competition period, and then like you're going to be a much more explosive athlete. Would you say that's a fair assessment?
Perfect. I'm going to add one more thing.
Okay.
And train the conscious awareness
Yeah,
of that
of course.
patient in that position.
Yeah.
If they're not conscious of it, man, I have to get that higher order thinking from the cortical to subcortical. Okay, if I do something enough, repetitively, as you were saying, with best NBA players that you've
Right.
worked with, don't practice in the off season.
Right.
So essentially with that conscious awareness, over time adaptation will occur. And guess what? I don't have to remember how to shoot a jump shot, even if I took 3 months off.
Purposeful.
Yes.
Always say everything.
Sure.
Always say purposeful.
Sure.
Purposeful. I don't think people realize what he's getting at with purposeful.
Well, this stuff is so tedious, right? So like when you're actually doing it, it's a pain in the ass. It sucks, and it's not one of the things that I'm preaching now is like this the new wave of mental toughness, and it's like mental toughness really is no longer what you're doing in the gym and sweating, and you got the Gatorade dripping from your pores because nobody's watching and the lights are off in the gym and you're running stadiums. It's now how long can you mentally lock in on working on your breathing, or like him and I were doing this thing the other day. I don't know what it was, but we were just like shifting into internal rotation on one of the hips. I physically could not do it, and I wanted out of the exercise immediately because I was unsuccessful. But that's mental toughness. New mental toughness is now it's that.
Yeah.
If you're on that level.
Yeah.
Right.
Yeah, interesting enough with that, Meg knows I like to squat in the weight room. And there are times where I'm so amped, I'm so sympathetic before I get underneath the bar. And I've noticed that if I drive myself into a sympathetic response, fight or flight, my lift is gonna suck. Of course, when I carry out and pick that bar off the rack, I'm gonna explode. I need that sympathetic. But before I take that rack, I'm on the wall, closing my eyes, lowering my heart rate, lowering my blood pressure, going to a parasympathetic state, because if I'm in a heightened state, fight or flight, I may have a biomechanical fault, and I don't want to injure myself. So that's.
So you only want to switch on the sympathetic state as you move the weight? Is that what you're saying?
Right when I come from, I would come here, boom, locked in, I'm ready to explode.
And then get out of it again?
While I'm performing the action, I'm going to be sympathetic.
No, I mean,
Like in
okay,
between a set, you try to go parasympathetic.
Not in everything. I'm just saying, like if I'm going heavy weight, where I'm really just, let's say I'm just squatting, just for today, so I'm working on some
Right.
strength. I'm going to change, because if I'm so amped, I've noticed that then my postural.
Well, yeah,
it's going to be
recover as well
yeah.
in between.
Yeah.
Not going to be as purposeful.
Yeah, and think about it. When fourth quarter, 2 minutes left, of course I'm going to be in a sympathetic state, but if I can't lower myself in the huddle, I'm going to miss what coach says. And the attention to detail in that huddle needs to be optimal, because guess what? If I don't hit my screen correctly, if I don't know where this guy's going to be running off the double screen, I just lost the game for us. And if it's game 7 of the finals, which is I've worked my entire life for, I'm gonna be pretty upset if I can't lock in.
I think a huge part of that is your emotional control in parasympathetic versus sympathetic. Once you go sympathetic, your emotional control is pretty much out the window, which is where you, if you're purposeful movement, conscious thinking, you go to a very much more protective state of aggression, which is good when you move weight, but to come back to parasympathetic and regain that emotional control and focus for the attention for mental toughness.
No doubt.
Big difference there.
Beautiful.
So one other thing is I just joined the gym about 2 months ago now, and I know there's this thing about, people saying, "Oh, PRI is not for the weight room." Every exercise, because I'm patho, so if anyone's taking PRI, you're gone. So you like to pattern, right? I like to go into extension. So I do every freaking exercise I do is modified to try to keep the left side a little bit more. And since I've been doing this, since I returned to the gym, and now I'm evening out my leg length issue, no soreness. And I'm getting stronger. No soreness. Anytime my legs used to get so freaking sore just from any exercise, even if it was just body weight, if I did a new exercise, I would get insanely sore. No soreness. I'm getting stronger, so why not?
Yeah.
Like, I don't know if you're training for football, you have to be as strong as possible. I don't know if that's Stanford's philosophy though, because I remember a newspaper article years ago about it. But why so anti-modifying? Why stay in extension during exercises if you don't need to be, if you can get a better training effect out of it? So I don't understand when people are like, "Oh, that's not normal. Don't modify exercise to stay in a better position. Just lift." I just don't see that. And I guess it depends on your goal also, but I'm not sore at all, and I'm getting stronger. I'm filling out my shirt again, like.
You look good, man.
Thank you. I appreciate it. And all it does, especially for just normal lifters, people who are not trained for any particular sport, like, they don't need to be doing a lot of this stuff in such extreme states of extension. They're just setting themselves up for future major issues. I'm watching it all in the gym, like shit I used to do. I used to do the same crap.
Yeah.
And they think they're using good form because they're arched, they're doing the rows, they're doing tricep kickbacks, and I was like, "Oh, do you know what you're doing to yourself?"
Yeah.
You could easily do that with a neutral spine, feel it better, get just as strong, probably get better muscular development because now you're balanced instead of going into these extreme states of extension. The idea that you shouldn't do this stuff in the weight room is just.
Fitness is one of those industries where I'm sure there's a lot of them out there, some I can think off the top of my head, where everyone just assumes they know what to do. And it's like an assumed thing across the board. like if if I'm not getting my results, I'm just not working hard enough, right? I'm not doing the craziest stuff in the gym, which is why. And it doesn't make sense. I mean, people are Googling workouts, which is, but we've all been there, right? We've all done it. But it's like when you get to this level, when you're sitting in this room, it's like, what are you doing? Yeah, you're
I'm
killing
talking
it.
about people who know about, say, PRI or DNS. And I remember listening to a podcast, I'm not going to say who the people were, but the one guy who was like a well-known person, like, "Oh yeah, PRI, not for the weight room."
Yeah.
Why not? You can't take away the fact that you're asymmetrical.
Right.
Take that into account.
Right.
It doesn't make sense to me. Unless you have, honestly, it doesn't, I can't even be like, unless you're in this situation, maybe for football training it's different because,
I think the only thing that they probably don't get about the weight room, and maybe, I don't know if this is where that person said, but I've been on record saying the same thing, and I don't think they understand like the dynamic of what it might mean to be in like a professional weight room where a guy will literally tell you to get out of my face with that. Okay. You know what I mean? Like it belongs, no question, but like when I worked for the Lakers and I had somebody do breathing, I got 30 seconds to make them jump 7 feet higher, or they'll never talk to me again. Right. I think that's where they don't necessarily understand. But I mean, the science of it absolutely belongs in there. The science of this belongs in there, but the dynamic. I mean, even those of you guys in the college setting. I remember Coach B used to have us. I hope he's watching right now. That'd be great. We used to do like alligator breathing from FMS. Yeah. And dude, are you kidding me? I wasn't doing any of that. I was over there like, yup. Mm-hmm. I remember doing dead bugs on the court at Quinnipiac, and say, and he would always preach to get our low backs down, obviously, and I was just like, no, it's stupid. I feel way more when I arch back. So I would do dead bugs arch back because I'm like, I feel it more, right? And it's just like the dynamic of an athlete, like, and it's again off that we already know what to do in the weight room, right? It's not. When I started strength and conditioning, I thought I was good. I thought I knew it all right from the start. Sign me up. NBA, here we come. Like way off.
Yeah.
But that's what I thought, and that's the stigma we fight.
Yeah.
I feel like we've learned to, like, I'll get my kids into like a neutralized PRI based position or coach a position that way without telling them like what I'm doing to them. So like I used to do a lot of like an individual basis, like putting them like, let's get you at 90-90, getting you to feel, you know, hamstring adductor, you know, let's get you out of that anterior position. But now I've learned a lot from B and like the PRI just to like sneak it into an exercise. Like, hey, we're gonna put our left foot up here today. Like, don't tell them, just have them do it, and they'll struggle and they'll understand. Like, they'll understand that they're feeling it more, but they don't necessarily know what we're doing, especially with like rotational sports.
Sure.
Like, you want to throw 98, 100 miles an hour, then let's do it this way. You know, instead of saying like we're gonna do a PRI based program.
Yeah, absolutely. And what we're all getting into, and with this discussion right now, is what the next, I believe, is the next slide with functional joint centration. And the biggest buy-in for my athletes, no matter if they're in the NFL, if they're in Division I, whether they're a high schooler, the biggest buy-in that I can get is put them in a position that they say they own. Okay, I'm going to show you that you can't hold it for 15 seconds with them going like this.
Yeah.
And you know, if Sean, if you could speak upon this. Well, we were working in the office the other day with the rotator cuff. You know, how we just put you in a position.
Oh yeah.
And then different pressure points on your hands, how you felt different muscle fibers.
Yeah. I mean, I don't even know what the hell you're doing,
No.
but
Or what did you feel?
I mean, I felt all. Well, it was actually interesting because he was just putting pressure on different points in my head, and we were prone.
We were in a
and-
prone 3-month position. Okay,
Yeah.
and I'll show you what position we were at. Okay, okay. So see the top left, right there. That's the position that we were in.
Yes. So you just put pressure on different points in my hand as I like lifted it up, and it was like a piano, like going down the keys of my rotator cuff. He's like, what do you feel? I think that's like supraspinatus. And then he's over there getting his jollies while I was doing it. And I was like infraspinatus, and then teres minor, and it's just literally going down the line. And you know, I worked in pro baseball for 5 years, and I mean, how cool would that have been to have something like that? And I mean, anything you do for if you talk baseball buy-in, anything you can do for a shoulder, they'll be in on that, and that would have been really really cool to have some sort of variations off of that, you know, back in the day. But I mean. And then we talked about how botched rotator cuff strengthening is in you know the bands and whatnot, but I was really interesting to see how that plays out.
Yeah, because at first I was like, I'm going to put you in a position that's going to cause your rotator cuff to be on fire without doing any concentric or eccentric activation. It was actually isometric. I had him in the prone position, and all I had him do was extend his wrist, and I went from the second knuckle, third knuckle, fourth knuckle, fifth, and different parts of the hand were activating different parts of his posterior chain swing. From the distal isometric resistance of the hand was activating his subscapula. So I don't need to do a internal rotation exercise to strengthen the subscap. Perhaps I put him in a functional centrated position, dynamic functional position, and just apply some resistance in the distal segments. With proper breathing patterns, man, are those things going to light up like a Christmas tree in Rockefeller Center.
What would the pinky correspond with?
I'm not going. I can't tell you exact muscle, but I
What
will.
do you got?
Or
over
you
there?
got it.
You're
Come on.
very ready. You're smiling. You got it over there.
No,
Say it for the camera, Neil.
no, that's just things that come up over lifetimes and thinking I had pre-arthritic pinky, then I got a full squat finally.
Mhm.
After stretching my calves, I got into a full squat, and then I found this more arthritic finger. So just all these little things, I'm like, I always like to hear whether it's Chinese, foot reflexology. Like, I always find it amazing with reflexology. You know where the spine is, arches of the feet. People who are supinated, they have
Sure.
So I'm like, holy shit, they knew it. If you're not pronating, you're locked up. Like, so I always like to hear other disciplines, because I don't have an explanation for this.
Yeah. Well, that's why we're on this journey together, man. That's why we're here.
I'm still trying to figure that
Yeah.
one out.
So, yeah, great discussion. Thank you. So, and going back to the 3-month prone position, this brings me back to a story at Stanford University. And my boss at the time, Scott Henderson, one of the greatest clinicians will meet in my life. And I am so thankful for him. But I went to him. I had a synchronized swimmer who was having a hard time doing lifts in the pool. You know, and based on the orthopedic evaluation that I learned in school for 4 years, well, I came to a determination that we have some type of muscle weakness because, you know, on manual muscle testing, there's weakness of the shoulder, you know, specific muscles. I was telling him, yeah, you know, 3+ out of 5, 4- out of 5, yada, 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 whatever scale you want to use. And my boss looks at me and he goes, shoot, should we get an MRI? Like, this is bad. You know, she can't lift. We have to win a national championship. You know, a lot of pressure on the line. But like, you're telling me that there's a muscle tear because there's weakness. And I was like, well, I'm pretty sure with the mechanism and how she's been complaining of decreased strength over time over the last 3 weeks, you know what? It's not an acute situation. So actually, I don't think there's a muscle tear. So then he's looking at me and he sees my fireworks in my brain, like, what is going on? And he goes, it's not weak. The neural connection between the brain and the muscles of the shoulder needs to be cleared up. So I trained her in that 3-month position. I didn't do one internal-external rotation exercise. I did not. We did some low trap, you know, open kinetic chain band work. But it's not to. I wasn't saying to strengthen the low trap, which I would hear a lot. I choose that exercise because what people will do with the band, they're going to be here. Give me the black band because this is too. You know. But no, what I want you to do is, and mind you, I'm not putting it into an internal rotation position. I want external because why am I going to put this into a decentrated position? I want to be here. Why this is anatomical position for a reason. So I'm here, and I want this. I want, okay, let's descend. Okay, and now let's use the scapula and the glenohumeral joint functionally together, and now let's pull this back. And you know, I take the lightest resistance, and they're like, oh my god. And then as fatigue comes into play, and you'll see this, and then you'll see this. So why am I going to, if I start seeing this, why am I going to train them during that? I'm not. Exercise is done. So, based on the evaluation, she had muscle weakness, right? We didn't do traditional strengthening exercises, but within 6 weeks she was full strength. Her scapular-thoracic rhythm improved dramatically. The tone in which of her power spinals, when she went up into that 3-month prone position, if I show you the video, you're going to see the right paraspinal muscle on fire. Okay, if I showed you the video at the 6-week mark, the tone is not there. Okay, the hypertonic state's not there. It was a good healthy tone, and it wasn't hypotonic. How does the pattern of stabilization and respiration become disturbed? Of course, there could be a congenital abnormality, abnormal early development. We have cultural, sport, and habitual reasons for these compromises. And any type of protective pattern due to pathology. Functional joint centration, we've been touching upon this a lot. And this is achieved through coordinated co-activation, co-contraction of the antagonist muscles. So this allows us for the greatest biomechanical advantage, which is ideal loading. You know, if I'm going to decentrate the shoulder joint, well, I'm going to decrease force production. I'm going to decrease co-activation of the shoulder girdle. I'm going to increase repetitive strain, and I'm going to increase loads on the joints, discs, and muscles. So it's very hard to throw a baseball efficiently, you know, without. Of course, we're going to have some compromise. You know, that's we need that for the sport to compete at a high level. But if I can't train and get an athlete into a functional centrated position, well, I'm only going to inhibit their ability to be coordinated in that, but also I'm going to be increasing all the strain, and I'm not fixing anything. I'm actually loading them even more in improper ways. So that shoulder girdle, for a guy that throws 96 miles an hour, that shoulder and elbow have a lot of force going through it. The load on the joints, the muscles, the ligaments is so great. So why? They have to do that in a decentrated position to throw 100 miles an hour. But why? The reason why I'm doing this is to make them to improve their efficiency and create their awareness through a positive experience. So functional joint centration is what I'm looking at all the time. If I have somebody that's doing let's say a half kneel exercise, we're on one knee, and their hip is hip hiked, and I'm doing a split squat, and we have this hip hike. Well, now we're getting adaptive shortening of the quadratus lumborum. The centration orientation of the femur within the acetabulum is now compromised. Glute activation will decrease. Hamstring activation, co-activation of the hamstring and the quadriceps is going to be decreased, and I guarantee you we're going to have changes at the calf and the foot. This is a good representation of a centrated joint and a decentrated joint. And what's very important here is looking at the resultant vector of this compromise. So we need the concentric muscle activation and eccentric muscle activation within external motion within the joint to have proper resultant vector. If we have an imbalance between the concentric and eccentric muscle action, we're going to have, and with some type of external motion against resistance, we're going to have a compromised resultant vector. This comes from your biomechanical toolbox. This is what a decentrated joint looks like. So look at that right hip. Look at the contours of the left picture, look at the contours on the right picture. Why am I going to train somebody on the left like that and put load onto them? My first thing is I want them to understand how to sit into the hip so the contours of their glute, the tone of their glute is like the one on the right. And this could take 5 minutes, this could take 3 days, this could take longer. Everybody has different cortical awareness. And this is the first thing that when I'm training somebody, or rehabilitating somebody, I need them to understand what joint centration is. And at first they look at me like I'm crazy, but one of the most amazing things when I feel like where I've had the confirmation that I did an okay job or pretty good job with my athlete is when I'm no longer with them and they say, Marc, I know when I was starting to become faulty. I felt this, I felt that, that's where I'm like, okay, I did my job. Because Craig Liebenson, I was at his course a couple of weeks ago, and he said, and for those of you that don't know, he's a chiropractor by trade, but he is pretty revolutionary in the spinal rehabilitative world. And he was essentially saying, we have to have this awareness. First and foremost, we have to provide the athlete and client with a positive experience, and from there, that means you did a pretty damn good job, And the last thing that he said was saying, judge yourself by the clinician, judge your abilities and talent as a clinician, coach, or whatever job you do, by what your clients and athletes do when you're not there. If I'm in the room and they're doing it well, yeah, that's because I'm there. If I'm not there and they're doing it well, shit. That brings a tear to my eye because I know I'm doing something right. All right, so here we go. These are the developmental positions that we're looking at. They're 3 months old all the way to 12 months, 13 months old on the screen here. And this could be accessed off of the DNS website. They have some great resources there. And we have, this is a beautiful representation of the prone and supine positions. Okay, so the 3-month mark, you see the 3-month position in supine, and you see the 3-month prone position. moving down the chain and over to the right, same exact thing. Each month is correlated to a different position. So going back to what we were talking about, the postural reactions, the representation of the babies on the left, if I change their position, we're going to have subcortical activation of muscles in order for the baby to basically fix the posture that the body was just put in. So if we have some type of compromise there, we're going to be able to correlate it through ideal development, correlate it to ideal development and make a determination whether this person is, slightly delayed, on track, or above, in front of the curve. So now moving into our ipsilateral and contralateral patterns. And once we go over this, then we're going to go talk more about how do we take all these, the strategy, this approach, and how do we apply it to our clients and our athletes. So here we see the picture and representation on the right. And if I could just ask for no pictures for this one, please, and the next one. So essentially, the ipsilateral patterns develops between the 3 and 7 month mark from the supine position. Okay, the support function is on the same side of the body of the arm and leg. So look at the baby's right arm and the right hip. That is the support function. It is in contact with the floor. Okay, the left hip and the left arm, those are responsible for the phasic function. Okay, this baby is rolling from supine to prone. We'll need that support system from the right side, that support phase, for the open kinetic chain function of the phasic segments and extremities. This is very important because this is how we correlate it to sport. The pelvis and rib cage rotate in the same direction in the transverse plane. Take a golfer, if his rib cage and his pelvis is not rotating in the same direction in the transverse plane, this is I'm telling you, he's not in the pros. Yeah, he's not playing in college. So with ipsilateral patterns, we're going to see phasic function and stabilizing function on the same side. So this is the ipsilateral pattern in sport. If you look to the top right picture with this picture, look at this pattern, his right arm and right hip. Look at this pattern, look at his left arm and left hip. Those are the support function of this throwing mechanism. The right arm and the right leg, if you know pitching biomechanics, these are going to be phasic functions, and they're going to be essentially an open kinetic chain as he's trying to deliver this pitch. So look at this baby's right elbow in contact with the floor. Look at his left elbow. If there was a floor underneath him, he would be in that position. Same thing with the hip and the knee. If we look at Roger Federer, Sean and I were talking about this yesterday, and he's probably one of the greatest movers on this planet. Has he had many injuries? No. Why? Because he's a great optimal mover. Look at his left elbow, look at his left hip, support function, same exact thing as the picture. Open kinetic chain phasic function of the right arm, and he's going to have the stepping forward of the right hip. If we look at Tiger Woods over here, same exact thing. Left hip, left shoulder, stabilizing function, phasic function of right shoulder, right hip. So when I'm evaluating an athlete, I had a tennis player at Quinnipiac one time, and this is when I was like, wow, like this is some powerful stuff. Being able to take these DNS principles and applying it to your evaluation and observation of their sport. Like I said, the body's going to tell you a story through the tone, but the body's also going to tell you a story through its motion. So I had an athlete that came up to me once who had a lot of right hip. He was a right-handed player. He had a lot of right hip pain, TFL pain, right oblique pain, and he would come in just completely jacked up. Like, I'm in a lot of pain, and it's my senior season. I need to do something about this. And I was like, perfect. Mind you, I haven't seen him ever play tennis. Okay, not once. And based on the developmental positions that I put him in, And it's important to know that every position that we have is a test. You know, with the position that you're in, it's telling me something. You know, you have a flexion intolerant person, guess what? They're most likely sitting in their intolerance. You have somebody that is extension biased, they're most likely sitting in extension, which is like, wow, why? You know, but it is, if you observe it, it's, of course we have some variation, but that's really the common link. So we are in our dysfunction, and we have to train out of it. So going back to this tennis player, based on my evaluation, how his body reacted to the postural changes and the external resistance that I was giving him, I stopped my evaluation and got up and said, man, correct me if I'm wrong, but your backhand is where you lose most of your points in matches. And he goes, didn't say much. I said, there's no way you can, with all this adaptive shortening, that you can effectively hit a backhand. And I don't play tennis, but I'm telling you that your backhand, you don't rotate on your hip. Okay, so right-handed player, I'm coming, I'm backhand. All right, I need this motion, okay, to come around this hip to deliver that ball over the net. I said, but you can't do that, unfortunately, but we will get you there. What you do in your backhand, and correct me if I'm wrong, you side bend, sometimes you may even jump into it, and it's only a drop shot. It's only a drop shot. Looks at me and said, let's get to work, because you're right. And that's when I was like, wow, you know, this is some powerful stuff. And that's when, you know, immediate buy-in, but also it's very encouraging for a clinician because it's, with what you're studying, you're finding patterns and you know how to intervene. So, you know, am I going to be strengthening the TFL? Absolutely not. No way. You know, am I going to be strengthening the adductor of a soccer player? No, I'm not going to be strengthening it concentrically. We were talking about this yesterday. Neuroplasticity is a real thing, okay? And muscles are elastic and have elastic properties. We have concentric and eccentric properties of these muscle functions, so I must lengthen that. You know, adductor and rotator cuff, we must lengthen these muscles for these performance athletes. I can't get the external, why am I going to put the external rotators in a more contracted, adaptively shortened state for a pitcher? I am not doing them any good. I may be able to increase force production slightly, but guess what? If you look at the role of the rotator cuff in the throwing mechanics, I'm not doing them much good. Contralateral patterns. This develops from the prone position. Okay, the support and the dynamic function. Support function is on the opposite side of the body. So in this position, the support function is the left extremity and the right extremity. And if you look at the arrows, the dynamic phasic functions are occurring at the left extremity of the lower body and the right arm. And the pelvis and rib cage rotate in the opposite direction in the transverse plane. So what is a contralateral pattern? Crawling, tripod position, standing up, walking, and in sport, these are just some examples. Running, skating, cross-country skiing, jumping from one leg, and cycling. Look at the reciprocal motion of Connor McDavid in this picture, of the skiers and the jumper. All different sports, but same type of function. In the skiing picture, look at the right hip, right leg, that is the support stance, and the left leg is in the phasic function, and vice versa with the upper extremities. Athletic performance, this is where it all comes together. Everybody knows Michael Jordan. Everybody knows Michael Jordan's tongue. You think that is purposeful? You think that is conscious? No, it is not conscious. He doesn't do that on purpose. And I've looked at many pictures of Michael Jordan, and please, if you find one where his tongue, if the ball is in his right hand, and if you can find a picture that his tongue is sticking out and to the right side, please send it to me, because that'll be the first picture that I've seen in that type of dynamic function. When the ball is in his left hand, his tongue is all the way to his left side. When the ball is in his right hand, the tongue is central. It's down the midline. And guess what? When he's trying to win an NBA Finals championship, he's not thinking about where his tongue is. Okay, Professor Pavel Kolaj, the inventor of DNS. We were discussing. He works with many Olympians, and we were discussing with javelin throwers how he increased somebody's distance by at least a meter. So we're talking significant gain by tongue position. He did not change any biomechanical motion of the shoulder or anything like that. He says, put your tongue here and the magic is going to work. Because essentially think about the neurology. Okay, our eyes are very important. The development of somebody that is unfortunately blind is going to be different than somebody that has good vision. Okay, and at 8 weeks old we should have 100% optic contact. Okay, at 6 weeks old we have 75%. So if a baby is not given emotional support by their parents, and it isn't given external and afferent stimuli from the outward world, we're going to have changes.
You're going to be the greatest dad ever.
Or the most annoying.
Or the most annoying.
That too.
Oh, man.
Yeah. Your kid's going to be so functional.
Karate chop. No. So yeah, but honestly, that's something that's very interesting that I've noticed with Michael Jordan, and look at this Olympic tennis player as well.
Well, what is optimal tongue position for a jet thrower?
And why is the tongue not going right at all? You said midline and left, but you said
Yes,
it's
I
not
don't know,
going-
and you know what I would also be very interested to see is what are the percentages of Michael Jordan when he drives to the basket, whether he's going right or left. If he wants to take it all the way to the rack, I wonder if he's going to his left, okay, because if he's on his left side and his tongue is moving this way, well, that's the motion that we want to see, and essentially, there are basketball players there's a reason why somebody says, oh yeah, I like driving to the basket off of my left hand, even if I'm a right-handed dominant player. But if I have to pull up and stop on a dime on somebody, I'm going to go to my right. If you look at the percentages of LeBron James, I believe he goes left more often.
Yeah.
Okay, and if he goes to his right, he's pulling up. If he's going to his left, he's taken to the rack. So
yeah, guys.
yeah, so it's just something very interesting to see. So obviously, the eyes and the tongue, they mimic the muscles. Okay, this is developed early on. The eyes and in many different trades of performance training. All of us can have an example of when the eyes are important in something. So moving forward.
Wait 1 second.
Yeah.
Has anybody had any RPR experience?
Sure.
So you've done with B or no?
Yeah.
So you've done the vision with the colors and
Yep.
everything, how your body retains it.
Yep.
So I have a pitcher who, right-handed pitcher, so he's constantly looking to the left. And every time he's maxing out or going into like above 85%, he does everything with his head turned. That's where he finds his stability. And I'm just like wondering, like with the whole tongue, like there's also like points in your mouth. And with experiences you had, you related to a color, and if you see that color, you can't perform, you can't be conscious with your movements, all that kind of thing. So like, is that only from birth, or can you have like learned patternings in a position? Does that make sense?
I think both. But
I think with the tongue, even from like the pure eye perspective, like my thought, if I've never even heard this DNS stuff,
Yeah.
my thought would be, he's trying to find a way to get back to the left, right? Because
Right.
they say we can't go to the right.
Right.
Or we can't go to the left, we're so on our right. So
Mhm.
now he's just finding any type of awareness to pull
To get-
himself over to the left.
Right.
And he's just happens to use his tongue as that driver.
yeah, and then Neil, if you would like to speak on this in regards to PRI above the neck, and facial asymmetries and clenching of the
Be careful
jaws.
what you wish for.
No,
Might
it's
go for a while.
Yeah. Like what is from your experience? Because you're more of an expert than me with this in regards to above the cervical. But if you could please share some of your experience.
So, in terms of sports or just life? In
Life
general?
movement, we all can move.
Restricted. You're tight. So I was I guess you would classify me as the right torsion, but my facial asymmetry showed up at like 6 or 7 years of age because I found a picture of myself at that age. So in infancy I wasn't like that, and then once I was 6 or 7, you see my left eye significantly higher than my right, and the left ear significantly higher than my right. So in cranial pathological positions, if you look at a cranial sacral book, it might be a right side bend instead of a left side bend, or a right torsion. I don't know which one, because the CMO is the only difference. So I don't know what the hell I was in. But I had to quit pitching at 13 years of age because my shoulder just broke down completely. And this was back when we used to throw 3 innings, during a Little League season and then All-Stars. But we weren't playing year-round. It was 3 innings a game. That was nothing. I couldn't pitch. I could not hold my arms steady past the 7th or 8th grade after pitching 3 innings. So I had to quit throwing baseball. Tinnitus when I was 13, freshman year, I developed tinnitus. Plantar fasciitis in high school, and then again in my 20s for 4 or 5 years straight, both feet. First experience of lower back pain sophomore year in college, where it lasted about 6 or 7 months. It was just a freaking nightmare. It probably caused the crossbite, and the crossbite eventually threw me back. They just locked me up even more. But now that I realize I have a leg length discrepancy, which I never freaking, no one ever noticed, I never noticed. But I have this, about 6 millimeter lift in my right shoe to even things out. It feels completely different. So I'm wondering if those asymmetries showed my face because of an unstable base of support. It'd be interesting. I don't have an answer, but I mean, since in the past year, since getting out of this cranial lesion position, the tinnitus has decreased considerably. Decreased even more when I put this in to level me out. So to me, it was a grounding issue. I really think it was psychologically and physically, I was just completely ungrounded, and it can really ruin someone's life. I mean, chronic pain. Spine can't rotate. You have an occiput that's on an atlas that's not right. You're not alternating, so you're not creating any sense of side-to-side movement. You're always, in Peter I talk, you would be completely to the right. You'd have a left side of your right side and right side of your right side, but you wouldn't have a left side. So it's real, and it can really, there's nothing I can't interfere with, let's put it that way. Thank you.
So in regards to optimal performance, obviously we're looking at all the things that we've discussed in this discussion. We want reciprocal position and movements of the extremities. We want optimal timing. Look at the elite athletes hitting a forehand, backhand, overhead serve versus the timing of an amateur player. Their support function, once they, of the lower body, is going to be, it's going to be different than the amateur player. Their stabilization is going to be different. The timing is going to be different. And obviously that comes through conscious awareness, but also through time, it goes to the subcortical level. And obviously we want to have an optimal biomechanical advantage with joint centration, so we can allow full range of motion of that joint, so the muscles of that joint can then work at a greater efficiency. So how do we apply DNS in training? We must analyze the body segments, align them in a static position and during movement, okay? Because the static position that your body's in right now and the patterns that you're in right now could be different, perhaps different, while you're in a dynamic function. We compare the optimal movement pattern or ideal movement pattern from the pictures that we saw on the previous slides from developmental kinesiology. We take that as a comparison. Okay, if you look at the 3-month position and verticalize it, that is a beautiful, beautiful, beautiful squat position that is going to be similar to some of the best back squatters in the world.
Do you think adults should be able to squat like a baby?
Well, I believe all of us use the restroom, right?
Right.
We have to lower ourselves to the toilet
Sure.
You know, so I believe yes, we have to be able to squat to within ourselves. You know, we could make, if there's any type of capsular restriction at any type of joint, that could decrease our efficiency and range of motion of a squat. You know, if we have a true anatomical change, perhaps in a cerebral palsic hip, you know, no, they're not going to. But I believe we all should be able to.
That would be ideal. And then from like, if there's somebody who does have an anatomical issue, you'd have to seek that out, make sure that that's not a thing before you start trying to slam something down to a squat.
Yeah, absolutely. And a perfect segue is I have like Perthes disease in my right hip. You know, so at age 5, I had tremendous knee pain, and my mother and I uncovered this when we were late to school, and I was running to school. I said, I can't. My knee hurts so bad. And thank goodness I had a good pediatrician. And think about this. This is 20 years ago. Think about how much times have changed. He goes, all right, I'm ordering x-rays of the knees and the hips. Okay? A lot of orthopedists today, I need a lot of doctors today. Knee pain? Boom, let's get a picture of that knee. Well, my knee would have been perfectly fine. There would have been no changes. You could have done a CAT scan, MRI, anything you want. You're not going to find a damn thing. If you looked at my MRI, my imaging of my right hip, the femoral head in the acetabulum, it was like bone was not even formed. It was dead. There was no blood supply no oxygen, no nutrients to that joint. Okay, so think about now as
your hip didn't hurt? Or it did?
The hip did not hurt at first.
Okay.
At first. But now over time, I'm running late to school at 5 years old, 6 years old, 7 years old, 8 years old. And actually what's interesting with like Perthes disease is that blood flow comes back. It's idiopathic right now, and there's no known cause and they don't understand from my understanding right now, how the blood flow comes back. Well, with blood flow comes back, oxygen and nutrient-rich substances are going to come and form the bone and give it better bone density, as Sal was pointing to before. But during that time, you know, I would love to know now at what point or how long was I deficient with that blood supply, and when did that blood supply come back? And I would love to understand what movement I was doing then to fully understand why the hip became the shape that it was. And because of that, you know, I was a pretty good basketball player, highly functional and pretty athletic. And I had a doctor from Columbia Presbyterian, Dr. David Roy, and I owe a lot to him. And my case was brought up in many conferences. And if you're looking at the picture, and this is why, imaging is necessary in many cases, and it does provide some assistance and instant like approval of what we're thinking, or our clinical thought process and decision making. And I'm so grateful for this, because my life today would be totally different if he took the advice of others. And this is why he's one of the best orthopedic surgeons in the world. All the doctors were saying, you have to put this kid in a cast for 1 year. Forget about the anatomical trauma that would occur and the atrophy. Imagine the emotional response of a kid 5, 6, 7 years old in a cast for 1 year. You know, also, as I develop, my case was still in conferences. You must do this leg length procedure. You must. And he said, if you look at the picture of my patient, and you could look at his ability to function on my treatment table, and if you understand the ability at which he's performing on the basketball court, it would be negligent for me to do this leg length discrepancy procedure. Thank God he didn't. You know, that's a very invasive and, you know, big surgery. So, 7th grade, my hip I'm actually above the average height of somebody with like Perthes disease. So I'm 5'9". So at one point, my right hip grew to a matured size. So they had to stop the growth of the plate of the hip, because they didn't want it to cause further dysfunction if it continued to grow. So they stopped that in 7th grade. Sophomore year of high school, I began to have a tremendous groin pain. in my hip, and MRIs were negative, and essentially rehabbed for a year, came back junior year. I can't do this. I can't. After practice, after I am relaxing and the adrenaline stopped running, I couldn't lift up my leg to change my pants. I used to call my mother from the train station, which I had to walk 2 blocks. I said, "Can you pick me up? I can't walk anymore." I would be able to perform for the 3 hours, and you better believe that. But once I stopped, I was in agony. So, long story short, they're going in exploratory right now because everything's negative on MRI. I had a full rupture of one of the hip ligaments, and that's very difficult to do. 2, a tremendous amount of arthritis. 3, I destroyed my labrum. So they repaired all of that. Came out, rehab for a year, came back, played. Same thing. I could perform, but man, something's not, like I just can't. I feel terrible. I'm in agony after I perform. And at this point in my life, I was getting like mad at the sport. But you know, that wasn't the case. That shouldn't have been the case. I go back into surgery. They did a full osteotomy. They went into the femoral head, and it was like an egg and socket. They tried to make it more of a ball and socket. They took the greater trochanter because, let's go back to these pictures of the anatomical hips. Okay, this one is a leg half-perthy hip, all right? This greater trochanter, see how it's in line with the femoral head right there? Mm-hmm. Mine, this one, raised up here. So they had to cut that along this line. They had to lower it over here and then put 2 pins in. So it could look more like this. So think about functionally this up here.
I was thinking about your question about adult squatting, which I firmly believe they should. You see Middle Eastern cultures, they go to the bathroom by squatting.
Sure.
So you'll see it, that's like pretty common, and I think they have way better mobility, maybe not strength than we do, but also I was reading a study on the cultures that live the longest, and right now I think the #1 culture, or top 4, is Japanese hip culture. They don't use chairs or anything, so they squat and get on the floor daily through the whole routine. They go the longest, they say they attribute that to the longest lifespan. It's just them getting up and down and
Yeah,
being able to squat like a child.
I'm with you, man. I think that's it.
And then go on the topic. Oh,
No, I was gonna say, because you see a lot of other commercial advice there, like even the supple leopard one, right, would say you have to go parallel. And in the parallel, it's your femur pretty much parallel to the floor rather than going all the way down into your maximum reflection. What are your thoughts on that?
One more time, because I was just looking
Yeah.
at the cultural differences
Yeah.
of the hips.
Yeah.
One more time, could you just?
Yeah, so you know, like in certain coaches, advisors, book authors would say, you know, when you squat, do the parallel. And some, they will define what parallel is. Parallel would be that your femur is pretty much parallel to the floor. So you're not in full knee flexion when you're in the squat, and then your pelvis is not even in neutral or posterior tilt, right? But when you're in full squat, you are in posterior pelvic tilt, your knee and your hips are in full flexion. But then, you know, it's like, all right, well, in order for you to have a fully functional squat, you have to be at a parallel. But I kind of just find that to be a little counterintuitive. Because number one, you know, you're just fully extensor dominant all this time. You're not fully completing your range of motion. I don't know. I don't know what's accurate, what's true, and what is functional, and what's supposed to be a proper advice.
Yeah, I could have my thoughts. You know, if I said I had the answer, I would be telling you, I would be doing a disservice to everyone in here. When people are just focused on squatting for the term ass to grass, well, why? What's your goal? You know, if you have the biomechanical efficiency and ability, to be able to get into that extreme range of motion with maximum deflection, well, all right, well, great. Me, I will never, ever, ever try and train to go into that that ass to grass squat. Okay, what my goal is, because I have an anatomical deficiency, and I will tell you, I said years ago, I will never, ever, 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 ever be able to hit 90 degrees on a squat, ever. And Meg could you know, say something on this, but I've been working a lot on just mobility of the hip joint, being able to have that conscious awareness of what position that should be in, and with working with DNS, working with PRI, working with so many different types of philosophies and techniques and interventions, I'm hitting 90 degrees. You know, so yes, I have an anatomical compromise, but perhaps I wasn't hitting 90 degrees because capsular restrictions through adaptive changes over time. Perhaps my muscles weren't able to, they didn't know how to activate below greater than 80 degrees. You know, so there are a lot of factors. I think if you want to go to a deep squat with full maximal flexion, with your sacrum almost touching the ground, okay, but like if we're gonna load this,
Depends on, were you talking about in the context of putting weight on your back and doing it, or just
Right.
doing it fine?
So there's it's a conflicting recommendations really. It's like on one side, you know, don't go all the way down, don't go into posterior pelvic tilt, don't go into maximum deflection. And then the other is just like, right, stay just even 90 or slightly below 90, so that your calves barely touching your thigh.
Yeah, I guess it depends to me, it would just depend on whether you're putting weight on this person's back or not.
Yeah.
Yeah, I mean, if it's just your body weight, I think it's a great thing to
Yeah.
be able to do.
Yes.
But if you're putting a ton of weight on it,
Correct.
then I probably not.
Yeah, because now we're putting 320
Different
pounds.
activities.
Yeah, pounds.
Yeah.
300 pounds of pressure and an axial loaded position and a posterior pelvic tilt, going all the way down to that maximal squat position. That's not really good for my L5, S1, L4, L5, L3, L4 disc.
But, I mean, when you look at Olympic lifters, I mean, catching cleans,
Mhm.
they are
Yeah.
acid grass.
Correct.
You know,
Boost
they're-
grass, yeah.
And
Yes.
they do it well.
Yes.
Like form, anatomically speaking.
Yeah, well, I mean, I was gonna say, to answer your question,
Yeah.
I am a weightlifter, and so I do those activities, but I've also learned how to do them like with proper technique, and I'm always developing that. But I'm a personal trainer, and I work with Gen Pop clients, mainly like 40s to 70s. I don't feel the need to get them ass to grass. I think if they have the ability to do so just standing, like at the warm up, like, hey, can you do that?
Yeah.
If they can, if they're restricted, it's like kind of guides how I'm gonna train them that day, or if I'm gonna modify the workout. But I'm looking to see that, okay, can you breathe through this position? If they find that they're holding their breath even at the very bottom, but it looks good, I'm not okay with it. So, but for me, like, parallel is gonna be where I don't know the right terminology in terms of science, but like that's where the joint has the most resistance, or that's I forgot the name of it, but that's usually where, okay, that's good enough. If they have the ability to do it well, and they can go a little bit lower, ass to grass or whatever, I'm okay with loading it. But I don't do any axial loading besides maybe a safety bar squat if I see that they can do it good. Like, I don't have anyone do weightlifting, I don't have anyone do back squatting or front squatting really, mainly goblet. Or I'll just get them strong on like one leg. But that's what I see that they need, and there's really no need for me to
go a little more.
yeah, to develop them like as professional athletes if they're just trying to like go back to their 9-to-5 job and feel good. But,
Makes sense.
And speaking of the Olympic athletes, you know, I had the opportunity to be with Stuart McGill this past week and listen to him speak in LA. And going back to our cultural, our culture affects us, okay? And here I have some notes from his talk, and he was saying that if you look at the greatest squatters or Olympic lifters in the world, they're going to come from Poland, Ukraine, Russia, those types of countries in that region. They have a more shallow hip socket, okay, allowing a greater range of motion. But this also constitutes to the higher rates of hip dysplasia. Okay, the Scottish hip, you ever hear about that? as well. Essentially, this is more of a deep socket. Okay, these are from the countries Normandy, France, Scotland, and Ireland. You know, I'm not sure if you see many Olympic champions from those countries.
That's my issue.
There it is, man.
There we go.
I was just gonna ask, what about China?
Pretty big gap.
Yeah, so also I have here Japan is also within the group of Poland, Ukraine, Russia, and they have higher incidence of that.
So
Because I forget where it was. I don't know where it was.
So they're not gonna, the deep hip socket will not allow, they'll never be great squatters.
Correct. But they will never be an Olympic lifter.
Deep position.
Yeah.
Because I can get into a full squat and I can breathe. I can't hang out there.
It's not
and be
comfortable.
comfortable.
Yeah.
Same thing.
You'll either tip forward, tip backward.
But 1 year ago, I couldn't get down for one breath without falling backwards. Now I can actually get down there and breathe. So that's a big difference.
It's just,
My goal was to get a full squat. I was like, there's no way it's gonna happen.
let's just say I'm an
But-
atypical Asian.
Yeah, so then the individuals from the country of, Normandy, France, Scotland, Ireland, they have highest rates of femoral acetabular impingement.
That's so funny. That's what I'm working with
Yep.
right now. It's wild.
There we go. So I thought that was very interesting. And what Dr. Stuart McGill says is that Olympic lifting finds you, you don't find it.
What you said, Scotland, Ireland?
Normandy, France, Scotland, and Ireland have the highest rates of femoral acetabular impingement, highest rates of hip dysplasia, but also like the best Olympic lifters in the world come from Poland, Ukraine, Russia, Japan, who have more.
What sport is the Scottish good at? Do I need to start working?
I'll have to
The Highland Games, go do that.
Rugby or something. Things we don't have to bend over for. So it's a Gaelic issue, because the Normandy people from Normandy historically are the same race, if you want to call it that, as Irish and Scots. They're Gaelic. I believe.
Gaelic Saxons.
Saxons. Well, they live in Germany, right? Saxons one over in England. But at any rate, yeah, the North, yeah. So that's very interesting.
Yeah.
I never realized, that's why there's so many redheads in Normandy, France, because it's the same genetic population.
Did you give me any thoughts on
I was
why
actually
it
made
develops
it.
like this?
Well,
I can't say he elaborated
So now
on
you're
it.
using it, great.
yeah, no, I was like, okay.
I-
This sort of makes sense.
I can't say he elaborated a lot because in regards to that, because we had a lot of material to cover, but he speaks a lot in regards to on his podcast and stuff. You could definitely find that, but also what Matt was talking about in regards to these cultures, whether they sit a lot, whether there are different types of action or positions that they're in that's going to cause structural change. I'm sorry. Okay. All right. Oops. Let me just
I'm just gonna keep jamming my hip sockets until they give way.
One day you'll be in the Olympics, man.
So-
I'll find it.
Do you think that, let's say, a Scottish guy who's, let's say, predisposed to that hip anatomy, do you think that, let's say, he was adopted at 1 month old or something like that, and is exposed to a culture where, in, let's say, Japan or China, where that seated position is happening, do you think that because of the exposure to that, then there's going to be like a CNS adaptation and therefore muscular and joint adaptation that occurs, or is the overall like genetic factor overarching everything that has a much greater impact on everything else that can impact your life?
Yeah, beautiful question. I think if this person, of course, you're going to have a genetic factor. Our DNA from our parents have a huge role in how we function. But if you take somebody that is from a country and put them in a Japanese culture at an earlier age, I think, from my opinion, this is not a fact. From my own opinion, I believe you're going to have habitual changes to that. If I get adopted and I'm in Japan at 6 weeks old, okay, and grow up there, as opposed to I get adopted at 3 years old, it's gonna be different. So that's a great question, but that would be my answer.
But you would see compensation muscularly right? And then as that person, say he went there when he was 2 years old and grew up in Japan, this guy from Scotland. By the time he was 40 or 50, he would have some serious hip issues because he was trying to adapt his genetic disposition.
Yeah.
And you'd see that compensation factor, right? Like,
Yeah.
unless he had DNS and Marc Drobenko does that. Right,
Yeah.
right?
Yeah.
Like, because you can't change the hip socket anatomically,
Yeah.
you can't
No,
change
you
that.
can't.
Yeah, it's like the chicken or the egg, we don't have an answer.
Yeah, no, it's,
I think structurally, probably do a lot of changes, but physiologically, there's going to be. I mean, if you
Right.
just look at the experiences of immigrants, you know, so you look at people who are pretty much ectomorphic, turning into a different kind of body shape, second generation, third generation over, you know, just because of the kind of environment that they're in, you know, dietary, the type of things that they do.
Right, the environment.
And the environment really
Yeah.
has a lot to do. Yeah.
There's something called primitive postures, primitive positions. So, yeah, you can look those up. It's just some of them I can get, some of them I can't. But yeah, it's just something.
Primitive position, thank you for bringing this up, because I meant to talk about this. So, going to the neonatus. Okay, neonatus, okay? Functional immaturity, structural imbalance, no postural function, but we have the positive primitive reflexes, okay? Over time, these primitive reflexes, if we develop normally, or ideally, whichever way you want to put it, they should dissipate, okay? Think about a stroke patient. They go back into this primitive state, okay? The brain recognizes the primitive state as, I would say, a protective mechanism, okay? So what is in anatomical references the neonatus' posture, okay? From the hand, you're going to have at let's say 3 weeks old. The fingers are going to be in flexion. The thumb is going to be inside the hand. The wrist is going to be flexed.
I saw something like that.
Is this, is it
Cortical thumb.
Yeah, yeah.
At the elbow and forearm, you're going to have pronation and flexion. At the shoulder, you're going to have protraction and internal rotation. At the shoulder, you're going to have elevation. Okay. Now, at the shoulder, you're going to have elevation. Now, at the thoracic spine, you're going to have kyphosis. At the pelvis, you're going to have posterior tilt. Posterior tilt. Okay. At the hip, you're going to have flexion, internal rotation. At the knee, you're going to have flexion, external rotation. So that's the posture. So if you look at a stroke patient,
Like relatively quickly.
very
It's like
Increased tone and we'll go into the
Yeah.
position.
safety.
Is that the startle reflex also? Would you see? Would that be the position of arms?
I didn't think of it like that, but hey, I'm not sure, but you do bring a good point.
You definitely do that.
Yeah.
I think it's, but it's not so much of an internal, right? And the startle would be like more like a,
The reaction. I thought you bring it to protect the neck. I thought it was a shoulder.
I would imagine these shoulders would be.
I don't know.
If somebody scared me, now I'm just thinking from my own experience, if somebody scared me, I'm gonna go into extension. I'm not gonna crawl into flexion.
See, I do the opposite.
Yeah, so do I.
No,
I'm
Yeah.
like,
well, that
Yeah,
could be-
exactly.
Yeah.
And it happens a lot.
Fight or flight.
Yeah. And
Raise the shoulders.
yeah.
you're ready to fight, I'm ready to just, I'm done.
Fetal position.
I've given up.
Yeah, I just want to like go back to what you were saying about the sympathetic state when you're about to lift or do something. When you're in a sympathetic state, your muscles are also in a protective mode right away, and so you're less likely to be able to complete your range of motion, even if you want to, because your that reverse or that inverse stretch reflex that's supposed to happen once you hit your full range of motion is activating too early, right? And
Nicole in South Carolina.
Yeah.
She's an OT. She's working on this. She's doing research with police officers, military, because they're always in such a protective state and contracted that she's finding that their performance is significantly impeded and they're injury prone because they're always in this tensive state and they're not getting that full range of motion. So her work has been in trying to pull them into a more parasympathetic state through all sorts of different theories in order to kind of allow them cognitively, emotionally, and physically to like perform better, which I thought was really interesting.
So last two slides here to wrap us up. How to apply DNS in training. Align the body segments in a static position and during movement in a joint centrated state. Compare the optimal movement patterns from developmental kinesiology to how we move today, whether it's loaded or unloaded. The analysis of the sport technique, okay, there's no question about it. We have ipsilateral and contralateral patterns, okay, and some sports are contralateral more dominant, some are ipsilateral, and some require both. Analysis of the sport technique. Compare this technique to the global movement with trunk stabilization as the basis, and then you have the extremity movements for the ipsilateral and contralateral pattern. Rules to follow: keep all joints in a functional joint centrated position. Upright the spine. This enables segmental rotation of the vertebra. We must have sagittal stabilization, preceding any other type of stabilization in other planes. Regulation of the intra-abdominal pressure to the entire abdominal cylinder must be equal, and this is achieved from the 3 to 4.5 month stage. So this is our first stabilization that we acquire, so we should not lose it. Also remember, whether it's an ipsilateral or contralateral movement pattern, the shoulder and pelvic line are moved differently. In the ipsilateral pattern, they move in the same direction, and the contralateral will be opposite. And resistance against stepping forward function must have adequate trunk stabilization. If the trunk stabilization is compromised with that type of resistance, A, the resistance is too much, or B, they're not ready for resistance, and while maintaining the ability to keep all these joints in a centrated position. And